Hello, this is Stephen Bonsib coming to you from Arkana Laboratories in Little Rock, Arkansas. I have the pleasure of leading off with a 6-part series of talks about developmental abnormalities and cystic kidney disease. A major incentive for me deciding to give this series of lectures is that I think these abnormalities, which are actually very common and important in the area of kidney disease, really have no diagnostic home in pathology. Several fellowship programs could incorporate these diseases into their core curriculum, but I don't think many programs in surgical pathology, urologic pathology, pediatric pathology, or renal pathology incorporate this into their core curriculum. So my intent with this series of 6 presentations is to hopefully fill that educational gap. So this lists the 6-part series. It will begin first with a discussion of renal embryology, followed by 5 lectures dealing with the diverse developmental and cystic kidney diseases that are an important part of patients with kidney disease. The first lecture will be renal embryology, and I've entitled this Renal Ontogeny, which means development, mimics phylogeny, which means evolution. And let me explain what I mean by that. If we look at human kidney ancestry, it provides a glimpse of evolutionary history. And by that I mean there are 3 nephronic structures that develop in rapid succession over a 2 to 3 week period. This includes the pronephros or pronephric kidney, mesonephros or mesonephric kidney, and the metanephric or metanephros or metanephric kidney, the definitive adult kidney of humans. The pronephros is actually the functional kidney of a few primitive fish and the larval stages of amphibians. The mesonephros is the functional kidney of most fish and amphibians, while the metanephric kidney is a functional kidney of reptiles, birds, and mammals. So I would like to first demonstrate what these various nephronic structures look like and their evolution. The pronephros develops very early in human embryogenesis. It develops at 2.5 weeks and is a very transient structure which regresses by 3.5 weeks. It consists of 7 pairs of tubules that arise from the mesonephric mesoderm. And we can see these down here in this left image. Down at the bottom, you can see a few small tubules. In the middle image, you can see them at higher magnification. They are simply tubules connected to a short duct. And these very transient structures deteriorate cranially and form caudally, and the duct of the pronephric tubules fuse together and extend down and connect and become the mesonephric duct. The pronephros provides no secretory or filtration function, but is very crucial to the formation of the subsequent mesonephros as well as the definitive metanephric kidney. The mesonephros develops several days following the pronephros in the 3rd week of gestational age, and it consists of columns of 30 to 40 nephrons connected to the mesonephric duct. And we can see a microdissection study from Potter, published in 1963, here on the left, where on the lateral aspect we have the mesonephric duct visible, and then we have rows of glomeruli visible extending down along the mesonephric duct. At any given time, 20 to 30% of nephrons are functional, and they regress cranially and develop caudally over a period of most of the first trimester. The distal mesonephric duct fuses with the cloaca and the urogenital sinus, as shown here in this diagram on the right, and the urogenital sinus is destined to become the subsequent bladder. This is a closer look at the mesonephric kidney. We can see it consists of this column or row of glomeruli with a short tubule. The glomeruli look very similar to newborn glomeruli with very prominent row of podocytes and frequent capillary loops. They have a short proximal tubule, which you can see right here, which is a little larger than the distal tubule here, and this connects immediately into the mesonephric duct, which is not visible in this image. This provides limited filtration and secretory function for several weeks from week 6 through 10, and then degenerates near the end of the first trimester. The metanephros formation begins in the 5th week estimated gestational age. The ampullary bud arises from the distal mesonephric duct, and in this image from Potter's classic textbook on normal and abnormal development of the kidney, published in 1972, shows the mesonephric duct here on the left side, and then the budding ampullary bud coming off on the right side. The ampullary bud contacts the nephrogenic blastema, which is out here, and there is condensation where the blastema undergoes mesenchymal to epithelial transition with nephron induction. The ampullary bud itself is destined to form the ureter, pelvis, calyces, and collecting ducts, while the metanephric blastema forms the glomeruli, proximal and distal tubules, and loops of Henle. Now, the mesonephric kidney and the metanephric kidney overlap throughout much of the first trimester. Here on the left, we can see in this embryo, human embryo, the mesonephric kidney here down at the bottom, and then here at the upper left, the metanephric kidney is just beginning to form. And if we look more closely at these various kidneys, we can again see the mesonephric kidney contains glomeruli that look very similar to immature adult glomeruli. And down here we can see the proximal tubule transitioning into the distal tubule. If we look at the metanephric kidney right up here at higher power, we can see some of the branching ampullary bud and then early condensation around ampullary bud branches. Now, glomerulogenesis begins at 7 weeks, and it is arbitrarily divided into 5 stages referred to as the hollow vesicle, comma-shaped, S-shaped, capillary loop, and mature state. This is depicted diagrammatically in this elegant drawing by Max Brodel, published in 1915. Max Brodel is interesting because he started the first school of medical illustration at Johns Hopkins University in the early 1900s. And in his diagram here, we can see the ampullary bud, which is just beginning to branch here. Here we can see the hollow vesicles that have formed, and then condensation, which will subsequently develop into additional glomeruli later on. In this second image drawing here, we have the comma stage, and in this stage, primitive capillary loop and mesangial precursors indent the hollow vesicle and produce the comma stage. In the S stage here, shown on the upper right, there is extension of the tubular portion, forming the initial phase of the proximal and distal convoluted tubules, while in the capillary loop and mature stage, the lower portion of the S phase separates into 2 layers, the parietal and visceral epithelial cell layers. In the maturing stage, there is further capillary loop branching and tubular elongation, and the proximal and distal tubules develop additional convolutions, and the loop of Henle forms and follows the collecting duct down the medullary rays. Now we can see these stages of glomerulogenesis in this 7-week embryo. Down here on the lower portion, we can see again the mesonephric kidney, and then we have the developing metanephric kidney here. We have a undifferentiated gonad here, and the liver we can see right here. And if we look at this portion of the metanephric kidney, we can see an ampullary bud branching and hollow vesicle formation forming. If we look at embryos that are slightly older, again, we can see the ampullary bud branching, some early condensation, the beginning of mesenchymal to epithelial transition. We have the hollow vesicle formation right here. If we move to the middle image, we can see the comma stage with early indentation. If we move to the far right, we can see the S phase and the early separation of the parietal from the visceral epithelial cells, and then further maturation as we proceed deeper in the cortex. Now the metanephros, while glomerulogenesis is occurring, is also forming the collecting system. These are occurring in parallel. The first 3 to 6 branches form the renal pelvis and calyces, and this is shown here in this drawing from Potter's book, and it shows dichotomous branching occurring with the initial phases forming the renal pelvis and then subsequent calyceal formation. The branching becomes more numerous in the upper and lower poles, and those areas have more lobes than the middle portion in the fully mature kidney. By 10 weeks, the renal pelvis is forming, and we can see this here on the upper right, where we have the renal pelvis, while this 10-week embryo is undergoing glomerulogenesis. And by 14 weeks, the renal pelvis is well formed, as shown in this microdissection here, where we have the renal pelvis, we have major calyces well delineated, and just beginning formation of the minor calyces with a number of glomeruli already formed. Now, glomerulogenesis proceeds in a centrifugal fashion, meaning we get successive layer after layer of glomeruli formed, and this diagram shows that the glomeruli form rows and arcades of nephrons, so we have row and row formation, and glomerulogenesis proceeds outward as the fetal kidney continues to enlarge. Now, the enlarging lobes, which represent the 6th to 11th ampullary bud branches, fuse, and their lateral junctions, shown here in this 22-week kidney, are destined to form the columns of Bertin. Nephrogenesis is completed by 32 to 36 weeks, and in this 36-week fetus right here, we can see there is no longer any nephrogenic zone, and we can see row after row of glomeruli present. Now, the newborn kidney is simply a smaller version we can see in this gross photograph of the adult kidney. We can note that there is very prominent fetal lobation, which is largely lost as the kidney enlarges. The difference between the newborn kidney and the adult kidney, the massive size difference reflects a marked increase in glomerular and tubular cell enlargement and tubular elongation. And we can see this in these microdissection studies, where the glomeruli here are much larger in the adult versus the 38-week fetus. Similarly, the tubular diameter is larger and the tubule itself is much longer. The normal adult kidney, the size and weight shows considerable variation between the sexes and within the sexes. Notice the average weight for normal kidney in women is normally listed as 115 to 150 grams, while in men it's 125 to 170 grams. So there is a considerable range in weight in otherwise normal kidneys. One explanation for that is demonstrated in this table, in which nephron quantitation or glomerular quantitation has been performed in a large series of patients of differing ethnicities, as well as infants to adults. And over here on the right column, we have the average number of glomeruli, or the mean number of glomeruli, in these various studies. And the number usually listed in the literature is in a range of 900,000 to 1 million glomeruli per kidney is considered normal. That said, there's a 13-fold variation in nephron number in otherwise normal kidneys. And by normal kidneys, I mean kidneys in patients that have normal renal function, normal serum creatinine, and normal and no proteinuria. And if we look at these numbers in some of these studies, for instance, African Americans, 176 individuals, the glomerular number ranged from 210,000 to 2.7 million. Similarly, we can look at some other studies and we can see 331,000 to 1.4 million. So there's substantial variation in nephron number between normal kidneys. This has some significant clinical importance, which will be addressed when I discuss renal hyperplasia in segment number 3 of this series. So I'm going to conclude with two more slides, both of which lead off with a quote. The first quote is from Edith Potter on normal and abnormal development of the kidney. And she states in that book, the more complicated an organ in its development, the more subject it is to maldevelopment. In this respect, the kidney outranks most other organs. And I think the 3 nephronic derivatives discussed early in this lecture, I think, attest to the fact that the renal development is a very complicated event. And because of that, there are very many developmental misadventures that occur. There are at least 40 types of renal developmental abnormalities in cystic kidney disease, and most of these will be discussed in the ensuing 5 segments. And I will conclude with a quote from the Orphanet website, which is a website of rare disease. And on that site, they state, rare diseases are rare, but rare disease patients are numerous. And evidence for that is that although individually most developmental and cystic kidney diseases are considered rare, in aggregate, they affect about 10% of the population. They are the leading cause of end-stage pediatric renal disease, and the 4th leading cause of end-stage kidney disease in adults, and therefore they represent the renal pedigree of many renal transplant patients. So segments 2 and 3 will discuss a subgroup of these rare diseases known as congenital anomalies of the kidney and urinary tract, abbreviated KCUT, and I hope you will tune into these episodes. Thank you.